Good morning, respected Emeritus Chairperson Dr. Swankar sir, Dr. Suresh sir, Dr. Achal Gulati sir, respected seniors, colleagues, and my dear friend. I am Ajay Goenka from the Department of Pediatric Neurology. After working in America for 12 years, I came back last year and joined and started the Department of Pediatric Neurology. In addition to the typical outpatient and inpatient facilities that we are providing, our department is focusing on 3 major programs. The first major program that we are highlighting is a Learning Disability Center. It's a unique and first in Rajasthan to help the students and the children with their academic, behavior, emotional and social needs. Second is the development of a electrophysiology lab with video EEG capacities. And the third program is our epilepsy surgery program. So let's talk a little bit about it. Learning disability is a very complex process. Even when I was in US, the maximum number of phone calls I used to get from the parents was कि बच्चा हमारी बात नहीं मानता, चिड़चिड़ा रहता है, सुनता नहीं है, memory कमजोर हो गई है. And the only answer I used to tell them that this is a very complex situation. We need a comprehensive approach for them. So keeping that in mind, we started this center. We started by developing a very simple 10 yes and no questions. We have gone to over 15 schools. We talk to the teachers, give them this screening tool. And if any student found to be positive for any learning problem, then we do a comprehensive evaluation for these children. The comprehensive evaluation includes a general pediatric examination, followed by a neurological examination for any subtle seizures like absence seizures, followed by ENT evaluations for any auditory processing disorders, and then physical therapy, occupational therapy as per the needs of the children. After getting input from all the teams, we make a comprehensive approach and a plan for these kids to help them the best. We have conducted a couple of Jaipur Swasth Charcha in various schools. The first was in Adarsh Vidya Mandir and the second was in Seva Sadan School. Seva Sadan is a charity school which runs in the Kachi Basti in Sodala. There are almost 200 children who go there. It's completely free of cost, cater all the Kachi Basti students there. Despite limited resources, they are doing such a good job. We go there frequently, talk to the teachers, talk to the students and try to help them as much as possible. Going forward, we have planned to go to schools whose special needs schools like Disha, and also to the blind school which is I School in Bhankarota. We are talking to them, but we have not set up a formal meeting, so we are planning to do this month also. Last month was Learning Disability Awareness Month. We conducted multiple poster quiz, slogan quizzes, also health talks in the atrium and the various schools to increase the awareness about learning disability. There are more than 10 lakhs children within Rajasthan itself who have some sort of learning or behavior needs, but the people don't know where to go and whom to approach. So this is a very much big required center for Rajasthan. The second big highlight of our program is the electrophysiology lab. Thanks to the administration, now we have 2 world-class continuous video EEG machines. One is a portable with a sleep montages also, which we use for the operating room as well as for the ICU monitoring. Based on the good work that we are doing, we are getting lots more referrals and our volume has increased by over 400% in the last 3 months compared to when we started. Our epilepsy surgery program is also growing. Dr. B. A. Sharma sir is heading the program. So far we have performed 11 surgeries. Our first case was in February this year. Initially we started with simple lymphadenectomies and now we are doing more and more complex procedures. When we started, we have to keep on lease the electrocardiography equipments and the software, but thanks to the administration, now we have in-house capacities of doing all these complex procedures. All these 11 kids so far are doing really well, so very happy to share that. Coming to the scholarly activities, we have submitted our research work both in the international as well as the national conferences. Our paper on the continuous EEG audio monitoring got accepted for poster presentation in the Pediatric Neurology Conference in UK this year. In the Indian Academy of Neurology Conference this year, we submitted 2 research papers. The one paper got accepted for oral presentation, which was presented by Dr. Ira Chaudhary, and the another paper got second best prize in the epilepsy category. So happy to share there were 200 research papers submitted for the epilepsy section, and among the 200 papers, our research paper got second prize. So very happy to share that. So Dr. Madhu presented this paper in the Indian Academy of Neurology Conference. So coming to the case, our patient is a very healthy, young, smart 15-year-old boy with abnormal movements. It's a multidisciplinary approach, and I will request Dr. Madhu to please come and take over the case.
I am Dr. Abnolrmal, third-year resident in Department of Neurology. I am here to present this case about a 15-year-old boy. Patient is a 15-year-old right-handed boy, resident of Bikaner, born to a non-consanguineous marriage, presently in 9th standard, presented with two chief complaints. First being episodes of abnormal movement for past 5 years. Second, poor scholastic performance for past 4 years. The first complaint is episodes of abnormal movement, which were first noticed by parent at the age of 10 years. I would like to show the video here as these episodes involve movement of face and mouth, hence the image is not blurred. As per parents, these episodes had impaired awareness and the patient would appear confused and would not be responding to any stimuli. He would often have these lid smacking movements, and associated with that there were some abnormal movements of all four limbs. These episodes lasted for a few seconds to over minutes, and the frequency of these episodes at present is 10 to 20 episodes in a week. The second complaint is poor scholastic performance for past 4 years. The patient is frequently missing his school days, sometimes because he is drowsy, sometimes because of the fear of having these episodes. Because of this, he also failed in his 8th standard exam and had to repeat it. Coming to the negative history, there was no pertinent history of fever, drooling, any aura, any tonic-clonic movement of any limb, no head injury or loss of consciousness, which was given by patient or the family member. The pertinent perinatal history was normal, but there was a significant past history of febrile status epilepticus at the age of 3 years. For this, he was not diagnosed and he was not investigated then and was not started on any medications. After this, he was okay and he didn't have any seizure till the age of 10 years. He didn't have any family history also. On general examination, the patient's vitals were in normal range and he had no neurocutaneous marker or any deformity. We did do a detailed systemic examination, the first being neurological examination. The first step in a neurological examination is assessment of higher mental function. For this, we used mini mental status examination. It is a screening tool used in OPD, which is a set of questionnaire and is scored from 0 to 30. With 30 being maximum. Our patient score was 30 by 30, which shows a normal cognitive function. We also assessed the cranial nerves, which were normal. The motor system examination was unremarkable. So was the sensory and cerebral examination. The patient didn't have any meningeal signs as well. The brief cardiovascular, respiratory and abdominal examination also showed no gross abnormality. So to summarize, we have a 15-year-old boy presented with a pertinent past medical history of febrile status epilepticus at the age of 3 years with two chief complaints. First being episodes of impaired awareness with abnormal movement of all four limbs for past 5 years. Second, poor scholastic performance for past 4 years. He has a normal systemic examination and the home video was already shown. So now I would like to put up a question for the audience. What do you think are these events? Can anyone just make any guesses?
Because it is very rare and I don't think the post-neurologists are aware of that.
Yes, thank you so much, sir. Thank you for your insight. We did investigate for these. I was just asking about the semiology, like when we see this episode, can we categorize them into any type of movement? So, with the clinical history and the home video, we kept three main differentials. These could be seizures, pseudo-seizures or movement disorder. For a brief understanding of these three, I would like to show here the definition of these. According to International League Against Epilepsy, a seizure is defined as transient occurrence of signs and symptoms due to abnormal, excessive or synchronous neuronal activity in the brain. A pseudo-seizure is, on the other hand, a paroxysmal event which appears to be epileptic but doesn't have any electrical correlates to it. A stereotypy in a movement disorder, according to the Movement Disorder Society, is defined as involuntary, non-purposeful, habitual, non-flowing, somewhat suppressible movement or vocalization which continues in the same form on multiple occasions. It can involve different body region each time. With the history and the home video alone, at this point of time, we have points in favor of either of them, and we are not precisely able to diagnose these events. So I have my next question for the audience, that what should be the next step to diagnose these events?
We can go for EEG.
Yes.
We can go for MRI.
Yes, you are correct. But I think in our last epilepsy awareness program also, we mentioned one specific tool which we can use to precisely diagnose these events. Yes, thank you so much. So to make a definite diagnosis, we did a video EEG of our patient. In a video EEG, the patient is monitored in an epilepsy monitoring unit where we intend to record the ictal event. During this period, the patient is ambulatory and is monitored by a neuroelectrophysiologist. In this video, we were able to capture the target event which was described by the family members. Here is a marker which is available for marking the event. Moving forward, this is a video EEG page. A video EEG is useful to see the congruence of clinical symptom with epileptiform activity in the brain. We aim to record the target episode as a gold standard for diagnosing seizures. In this video record, we can see the clinical symptoms in the small inset, and the simultaneous EEG of the patient can also be seen here. This is a 20 electrode bipolar montage with left side being depicted by odd number and the right side depicted with even number. We intend to see, this is useful for localizing the epileptiform discharges. Here, with the clinical symptom of the patient, we were able to see the first epileptiform activity in the F7 electrode, which corresponds to the left anterior temporal lobe. It gradually involves the left hemisphere and then continues to involve the whole cortex, as you can see here. This is suggestive of an electroclinical seizure. After the video EEG, we are now able to confirm that these events are definitely seizure. So my next question for the audience is this epilepsy? I think again in the last epilepsy awareness program, we discussed the definition of epilepsy. So you can point out any one point pertaining to this patient. Can you point out a definite thing which can suggest that this is epilepsy or not? Anyone from medicine would like to take up the question?
It is not common use.
Synchronization of movement and electrical charge.
Yes. Sir, when we synchronize the clinical and the electrical activity, it definitely suggests a seizure. But to define the epilepsy, according to International League Against Epilepsy, it is defined with either of the following. First, at least 2 unprovoked seizures occurring 24 hours apart. Second, 1 unprovoked seizure with further seizure with a probability of 60%. Third, a diagnosis of epilepsy syndrome is made. Now this is a very easy question for the audience. With the clinical history and the EEG, can you now point out that what kind of seizures these are? These are focal, generalized or unknown onset. Anyone from neurology would like to take up this question?
Focal onset was impaired.
Yes, thank you so much. So these seizures are definitely focal onset seizures with impaired awareness. After establishing the diagnosis of focal onset seizure with impaired awareness, we took a detailed drug history from the patient's parent. The patient was started on a monotherapy of oxcarbamazepine in 2019. But as his seizures were not controlled, the drugs kept on building up, and gradually he is right now on 5 anti-seizure medication, which include oxcarbamazepine, levetiracetam, lamotrigine, valproate and perampanel. Despite taking 5 anti-seizure medication, he is still having 15 to 20 episodes in a week. This fits into the definition of drug-resistant epilepsy. It is defined as a failure of adequate trial of two tolerated, appropriately chosen and used anti-epileptic drug schedule to attain a seizure freedom. If a third anti-seizure medication is added, there is less than 5% chances of seizure control. Coming to the causes of drug-resistant epilepsy, it can be broadly categorized into infective and non-infective cause, with structure being the most important cause of them all. To rule out any metabolic or infective cause, the patient underwent some investigation. Here is a brief summary of the investigation done, which showed no gross abnormality. With this, we are able to rule out any metabolic causes. We had a strong suspicion of a structural lesion, but the patient already had an MRI done from outside 10 days back, which was reported as normal. But in view of a high suspicion, we asked the Department of Radiology in our hospital to review these images. Now, I would like to call Dr. Karan Jani from the Department of Radiodiagnosis to talk about this. Thank you.
Good morning to all the respected teachers, seniors, dear colleagues and juniors. I am Dr. Karan Jani from the Department of Radiodiagnosis, and I would like to discuss the MRI findings of a 15-year-old boy with drug-resistant epilepsy. As the scan was done outside and reported normal, 10 days before it came to us for a review. After reviewing the images from the scan and getting the clinical information pertinent to the case, our findings were: this is a T1 weighted coronal section. Here we can appreciate that the left hippocampus is comparatively smaller in size to the right side. On the next image, in addition to the volume loss, there is prominence of the left temporal horn and absence of undulations on the surface of the left hippocampus. These findings are in favor of left-sided mesial temporal sclerosis. This is a T1 weighted coronal and axial section. Here we can see bilateral fornices and bilateral mammillary bodies are not involved, as the ipsilateral side might be involved in long-standing cases. This is the T2 weighted axial section. Here we can appreciate there is only a subtle difference in sizes of the hippocampi, as they can be routinely missed on the routine MRI. This is why we do a dedicated epilepsy or a harness protocol in patients with epilepsy. In view of these MRI findings, for further evaluation, a PET scan was done, and I would like to call Dr. Shubham to take the case further.
Good morning, all the respected dignitaries, faculty members, and my dear colleagues. I am Dr. Shubham Datish from Department of Nuclear Medicine. Why PET CT? Because FDG PET CT done in brain protocol is the most sensitive investigation for identification of seizure focus due to reduced metabolism in high background physiological uptake of brain parenchyma. Reduced metabolism, the probable causes in epileptic foci can be neuronal loss, diaschisis, or reduction in synaptic density. Other causes of hypermetabolism in neurology in brain parenchyma can be dementia, epilepsy, movement disorders, paraneoplastic syndromes, and metastatic brain lesions. In relation with video EEG and morphological changes in brain MRI, when we looked at the temporal lobe, we found that there is a reduced metabolism which is depicted as photopenic area in left mesial temporal lobe as compared to right, which is normal, which you can see in images that there is reduced area of reduced metabolism. On software enhanced images, we can further admire the reduced metabolism in left mesial temporal lobe, which is depicted as photopenic area. So we did a quantitative analysis and we found that the metabolism or FDG uptake in left mesial temporal lobe is less than that of 2 standard deviation of normal or right mesial temporal lobe. So the final impression was reduced metabolism or FDG uptake is noted at left mesial temporal lobe without any morphological lesion. So I would like Dr. Madhu to further take up the case.
So now with the help of MRI and PET scan, we are able to localize that these lesions are because of a structural lesion. Whenever we talk about structural lesion in focal epilepsy, we need to know about 4 zones. These are, first is ictal onset zone, which initiates a clinical seizure. Second, epileptogenic zone, which has a maximum propensity to cause a seizure. Third, symptomatic zone, which causes clinical features. Fourth, irritative zone, which generates interictal discharges. The target is to establish a congruency of clinical, EEG and imaging in demarcating the epileptogenic zone. And we were able to get a congruent clinical symptom localizing to the left anterior and medial temporal lobe, spreading on to involve the supplementary motor area. With EEG, we were able to localize the lesion in the left anterior temporal lobe. With imaging, the lesion is localized in the left medial temporal lobe. So, our epileptogenic zone is in the left anteromedial temporal lobe. In a child with seizure, we typically focus on the type of seizure and the number of seizure. But it is also important to understand the impact of these seizures on the quality of life. To assess this, we use 2 scales. First is the Global Assessment of Severity of Epilepsy scale, which is filled by patients attending physician. This is a 7-point questionnaire which is scored from 1 to 7, with 1 being not severe at all to 7 being extremely severe. A total score of more than 30 is considered to be severe. Our patient score was 39, which shows the severity of epilepsy. The second scale used was Quality of Life in Childhood Epilepsy questionnaire. This is filled by patient's family. It is a 2-point questionnaire which is scored from 1 to 5, with 1 being poor and 5 being excellent. Our patient total score is 2, which is suggestive of a poor quality of life. The patient also underwent a formal neuropsychological assessment on which the Vineyard Social Maturity Scale showed an average level of social adaptive functioning, and the Binet Kamath test for intelligence showed an IQ of 90, which is an average range. So to summarize, we have a 15-year-old boy presented to us with drug-resistant epilepsy with a semiology of focal seizure with impaired awareness, localizing to the left anteromedial temporal lobe, which is having a severe impairment to the quality of life. Coming now to the treatment option, it can be broadly categorized into medical and surgical. Medical includes anti-seizure medication and diet. The success of control after adding a third anti-seizure medication reduces to less than 5%. With diet alone, the success of seizure control is 10 to 15% on a lifetime diet modification. Because the patient was already taking 5 anti-seizure medication, we presented an option of epilepsy surgery to the patient's parent because it has a high success rate. To discuss about it in detail, I would now like to call Dr. Abnolrmal from the Department of Neurosurgery.
Thank you, Dr. Madhu. Good morning, colleagues, respected dignitaries, and esteemed teachers. So, our patient is a 15-year-old boy with medically intractable epilepsy in the left temporal lobe. Neurosurgery department was called upon to discuss the further surgical options for this patient. Before discussing the types of surgical options that we have, let us discuss about the preoperative evaluation and the goals of preoperative evaluation. So primarily there are 2 goals of preoperative evaluation in a case with medically intractable epilepsy. The first goal being to identify the ictal onset and the epilepticogenic zone, and the second goal to confirm concordant clinical EEG and MRI PET data with it. Evaluation is done to determine a single epilepticogenic focus that is not in eloquent cortex, therefore can be resected without causing an unacceptable neurological deficit. So, epilepsy surgeries can be further divided into the following classifications. It can be classified as a disruptive type of a surgery or a stimulative procedure. Disruptive procedures consists of transection type of procedures, resection procedures, disconnection procedures, and ablative procedures. Stimulative procedures can be classified under vagal nerve stimulation, deep brain stimulation, and responsive neurostimulation. The procedure that we did in this case was temporal lobectomy, which is classified under a resective type of procedure. Epilepsy surgery can also be classified into curative and palliative procedures. Curative procedures including lesional resection, lobectomies, and corticectomy. So we did a curative type of surgery in this case. The primary goals of curative surgeries are that the patient can live a normal life, preferably of all anti-epileptic medications, and become seizure-free at a younger age that can lessen the cognitive, behavioral, and psychosocial problems. So temporal lobe resection, also known as standard anterior temporal lobectomy, is the gold standard of medically intractable focal epilepsy in medial temporal lobe. It consists of resection of anterior temporal neocortex and mesial temporal structures consisting of amygdala, hippocampus, fusiform gyrus, parahippocampal gyrus, and uncus. Now, talking about the extent of temporal lobe resection, if the epilepticogenic focus is present in the dominant hemisphere, the extent of resection from the anterior temporal pole is 3 to 4 centimeter, and if it is in the non-dominant lobe, it is 5 to 6 centimeter. So in our case, the focus was in the dominant lobe. Now coming to the surgery, the patient was placed in a supine position and draped in a sterile manner. A curvilinear question mark incision was placed over the left temporal region, beginning 1 to 2 centimeter anterior to the tragus and extending upwards and posteriorly. A myocutaneous flap was raised. Now, as we were talking about the extent of the resection, it is important to remember that this extent, these values that we have, 3 to 4 centimeter, these are not standardized. So these margins are refined with the help of electrocorticography. To discuss about electrocorticography, I would like to invite Dr. Ira on stage.
Good morning, respected teachers, dignitaries, and my dear colleagues. I am Dr. Ira Chaudhary, DM Neurology Resident 3rd year. I am going to present the electrocorticography part. Neuronal activity in the brain gives rise to transmembrane currents, which generates transmembrane potentials, and recording of this electrophysiological activity directly by placing electrodes over brain surface during surgery is called intraoperative electrocorticography. For ECOG, there are an array of strips or drills with electrodes embedded in them and in a silicon plastic. Each contact electrode is typically 5 mm and spaced 1 centimeter apart. The monitoring time usually runs between 5 to 30 minutes. Longer is the recording time, greater is the sensitivity. What are the uses of electrocorticography? To localize the irritative zone, to map out the cortical function, to predict the success of surgery for epilepsy. This patient underwent intraoperative electrocorticography using a silicon grid with 6 5 mm electrodes spaced 1 centimeter apart. Once dura was raised, grids were placed over superior, middle, and inferior temporal gyrus, and baseline electrical activity was recorded. Electrode 1 represents the anterior pole and electrode 6 represents the posterior pole. This ECOG shows spike and wave discharges over the anteromedial region. We cleared all the margins with resection. After doing initial resection, ECOG strips were again placed over the margin and resection was continued till all the epileptogenic zone has been removed using electrocorticography. This is a post-operative ECOG which did not show any epileptiform discharges. To further continue with the case, I would like to invite Dr. Anmol.
एक सेकंड डॉक्टर, ये जो
waves you are showing, they are the alpha, beta, theta, gamma waves?
So
Recorded
the waves which we
5 types
see,
of waves.
alpha, beta, theta and delta waves, they are for surface EEG. This is the EEG intraoperative, which is for electrocorticography.
What type of these waves are? How will you name these waves?
So there are high.
So when we talk about the intraoperative monitoring, so we look for two things, which is called as one is HFO, which is high frequency oscillations, and second is called ripples.
So what is the difference in gamma waves and high frequency?
So when we record from the surface, sir, the skull is the barrier which impedes the transmission of wave from the brain to the electrodes. When we record directly from the brain surface, there is no barrier there. So we record much higher frequency, like these frequencies
So
are.
just these high frequencies almost similar to gamma waves?
Yes, sir, even higher than gamma. Gamma waves is like 70 hertz. These are 150, 250, up to 500 hertz, sir. So because of removing the skull, we can capture these high frequency waves.
Does the general anesthesia change the default findings?
That's a very
Yes.
good question.
Yes, sir, it does. For electrocorticography, we use halothane and low-dose propofol. Other anesthetic agents like barbiturates and the high-dose propofol and fentanyl in high doses can increase the epileptiform discharges. That is why we don't use them.
Actually, nowadays has been
mainly isofuran or sevofurant in lower doses and propofol in lower doses. Fentanyl or any opioid that does not usually interfere with the waves. So high dose fentanyl can be given, and a newer agent dexmedetomidine can be
used. Now I'll be presenting a short video that demonstrates the steps of temporal lobectomy that is being performed by Dr. D. Sharma sir. Initially, the cortex was marked with a bipolar from the tip of the temporal lobe along the upper border of the middle temporal gyrus. This is a picture illustrating the temporal lobe anatomy for orientation. You can see the superior, middle and inferior temporal gyrus. This is of the left temporal lobe. Then 2 incisions were made and neocortical resection was done. It is done till we see the middle temporal fossa floor. Then we proceed with the subpial medial temporal cortex dissection, and we proceed with the subpial dissection to locate the temporal horn of the lateral ventricle, which is being localized over here. Then we proceed with localization and identification of the uncus, and the resection of the uncus and amygdala part is done. Now, whenever we enter the temporal horn of the lateral ventricle, we place a cottonoid to prevent contamination of the ventricle, which has been done over here. This is followed by, after the resection of the lateral neocortex, it is followed by resection of the identification and resection of the medial temporal structures, which includes the hippocampus. The hippocampus is identified and dissected along with identification of the parahippocampal gyrus. Both the hippocampus and the parahippocampal gyrus, they are dissected of the collateral sulcus, and we can identify the posterior cerebral artery and the choroidal point. It is important that the resection should be maintained subpial at all times. The pia should not be disrupted. After the resection is complete, we can also identify the oculomotor nerve, the third cranial nerve, along with the posterior communicating artery. And in the end, meticulous hemostasis is done with bipolar and oxidized cellulose. And ECOG strips are placed on the posterior margins to confirm the extent of the resection.
So this is very fascinating for non-surgeons.
Yes.
So my question to you is there a difference in approach if you are doing on the left side versus right side, dominant versus non-dominant hemisphere?
So, sir, the first difference, the main difference is the extent of the resection. In the left, if we are doing it on the dominant hemisphere, the extent of resection is up to 3 to 4 centimeter. But again, these margins are defined with the help of intraoperative electrocardiogram. And on the non-dominant hemisphere, that can be extended up to 5 to 6 centimeter. However, in the textbooks, it is written that we have to save the superior temporal gyrus irrespective of whether we are doing surgery on the dominant hemisphere or the non-dominant hemisphere. Sir, so basically superior temporal gyrus, it has 5 basic functions. The first is that the auditory radiations, the auditory pathways, that is the Myers loop, it passes through the anterior part of the superior temporal gyrus. The second is that the visual, visual pathway, Myers loop, it passes through the superior temporal gyrus. Then the auditory radiations are present in the Heschel's gyrus, that is also in the superior temporal gyrus. And the Wernicke's area is present in the posterior part of the superior temporal gyrus. And both the temporal lobes, they help with the memory and the cognition of the patient along with the emotional behavior.
My question is, suppose this is a one-point focal area, the procedures. Let's say there are multiple foci of these seizures in a particular patient. Is it feasible to remove one hemisphere totally?
So, sir, there is also a surgery known as anatomical hemispherectomy. In that surgery, we remove one hemisphere.
Still the patient lives normal life because two hemispheres are there, so one can be sacrificed. Doctor?
Nowadays it is not done, it's a hemispherectomy. What we do is we disconnect all the parts.
Once you have disconnected, sir, then whether you keep it or you do not keep it, what difference does it make? Okay.
Just by disconnecting the material, you just disconnect it from the other place. The patient lives normal life except some
So we have done 2 cases of disconnection so far, and both kids are doing really well, sir.
we have done here.
2 disconnections we have done, sir.
This is alternative to the hemisphere.
So that's functional hemispherectomy. So we maintain the vascular supply and we only disconnect the pathways.
हेमिस्फेरेक्टोमी और हेमिस्फेरेक्टमी में क्या फर्क होगा सर?
Hemisphectomy is remove the brain. Automy is just disconnect, brain is removed.
So post-operatively, the patient was immediately extubated post-operatively and the surgical procedure was uneventful. NCCT head was done on the evening of the surgery and the patient was discharged on post-op day 5 without any neurological deficit. Our patient underwent a successful reduction of anti-seizure medications after the surgery and the reduction of seizures, they led to a better cognitive, social and emotional well-being. Now to continue the case further, I would like to invite Dr. Madhu.
Thank you, Dr. Anmol and Dr. Ira. After the resection, the patient was followed up in the OPD regularly. We performed a repeat neuropsychological assessment with the help of gas scale, which showed reduction in severity as his score improved from 39 to 8 on his follow-up. We were also able to decrease his anti-seizure medication from 5 to 2 over a period of 6 months. The quality of life also improved and it was assessed with CORE score, which improved from 2 to 10. Here, I would now like to show a brief testimonial from the patient telling about his journey.
जब मैंने बहुत सारी दवाएं ली थी 5 साल से, तो मेरे कोई फर्क नहीं पड़ा था। फिर मुझे डॉक्टर साहब ने बोला है ना ऑपरेशन करो। फिर मैंने ऑपरेशन करा लिया था और एक हफ्ते से मुझे है ना 10 दौरे या 20 दौरे आते थे और है ना कभी कभी मैं 24 घंटा चक्कर आते थे। अब मेरे एकदम ठीक है, MRI आ रही है वो भी नॉर्मल आ रही है, एकदम अब सही है।
Thank you. I would now like to call Dr. Pavni
So I
Agrawal.
think आपको ये वाला बिना चश्मे के खिला वो के तो वो कंट्रोल ठीक रहता है आपने चश्मा बिना ज़्यादा कैलिब्रेट बनाते हो
So he is going back to school 4 years. He never went to school. Sir. They were a joint family. They never went for a single vacation, sir. So it's just completely changed their lives, sir.
नहीं आजकल बड़ा नॉर्मल है MRI बोलना एक्सरे बोलना कि सर ये है वो है खास बात
I would now like to call Dr. Pavni Agrawal to tell us about the relevant literature to this case. Thank you.
Good morning to all. I am Dr. Pavni Agarwal from the Department of Neurology. Respected colleagues, dignitaries and my dear friends. I am here to present the review of literature pertaining to this case. These are two studies which were published by the Neurosciences Department from NIMHANS. The first study tells us about the epidemiology of epilepsy in India. This was a survey which was conducted in 2015. And as per this survey, there are about 12 million people with epilepsy in India, with the prevalence being 10 per 1,000 population. The other paper highlights the vast treatment gap of epilepsy in India. The major factors which influence this vast treatment gap are multiple, which includes the lack of knowledge about the disease and its treatment, including the knowledge about anti-seizure medications, various myths and prejudices which surround this disease, a poor health infrastructure in the country, among many others. There are about 90% patients with epilepsy who live in developing country and they are surviving without appropriate treatment. This is another literature which talks about the temporal trends of treatment gap of epilepsy all over the world. This is a meta-analysis which was conducted in 2022 which states that the pooled estimate of treatment gap all over the world is 71% and in Asia is 61%. A randomized controlled trial was published in the New England Journal of Medicine in 2000. In this particular RCT, 80 patients were divided equally in medical and surgical groups. And the results were such as the patients from the surgical group, around 58% of them achieved complete seizure freedom, as highlighted light color in the graph, versus only 5% achieving complete seizure freedom in the medical group. The positive results were not only in terms of complete seizure freedom, but also in terms of the quality of life of these patients, the attendance in schools, and later on employment in their lives. Hence, this particular literature strongly suggests the benefits of resective surgery, and this is what we also did in our patient, and this backs up our decision to do the same. This literature talks about the expansive innovative surgical techniques which are today available, such as stereotactic radiosurgeries, laser interstitial thermal therapies, brain responsive stimulation. But still, resective surgeries remains the reference treatment for patients with temporal lobe epilepsy. The effectiveness of resective surgery for patients in temporal lobe epilepsy in achieving seizure freedom is vast, and hence this again backs up our decision to do a resective surgery for our patient. This is a scoping review which was published in 2021, which ascertains the fact that epilepsy surgery is vastly underutilized, with around 10 million potential surgical candidates. And there are multiple factors which influence this treatment gap, which could either be patient-related, such as various myths and beliefs surrounding the surgery. Patients are very much scared to undergo any surgical procedure, and also various healthcare-related factors, which we further need to read about. Thank you so much. Now I would like to call Dr. Goenka sir to tell us the take-home message.